This conference will now be recorded.
Hello, good afternoon. Am I audible to you? Am I audible to you guys?
Yes, sir.
Yeah. Today's topic is osteoporosis. What is osteoporosis? Exactly, the osteo means it's bone, and porosis means it's like an porous. What happen in bone means normally the bone is it's like an compact structure. The inside the mineral inside the cortex, in the matrix, everything will be trabecular, will be tight compartment. It will be, but what happened in osteoporosis? It became porous, become wide opening, wide spaces will be there in the inside the quarter, that is inside the matrix. It become porous. Okay, it's almost it affect the systemic skeletal disease. Mainly it is characterized by low bone density, means it become both cortex and mineralization both will be low in osteoporosis. And compared with the osteomalacias and different all these, in those vitamin D deficiency and mineralization defect will be there, but in osteoporosis both mineralization and cortical defect will be there. That's why complete there will be low bone density will be there, and micro architecture deterioration of bone. Normally the inside the bone, the architecture will be, it's an compartment like structure, I mean it's an compact like, but in porous it will be the architecture will be deteriorated and and the bone will be fragility. And so due to the fragility there will be chances of high chances of risk of fractures. How to differentiate whether it is osteoporosis or osteopenia or healthy bone? Just see the BMD value, that means bone mineral density value. I will tell you how they will calculate this BMD value. Normally in healthy bone, the bone mineral density value is above they will say the T score is above the -1. In osteopenia it is the T score between -1 and between -1 to -2.5. In osteoporosis it is below the level of -2.5. Same thing if you come to bone porosity, in osteoporosis the porous will be very high and compared with healthy. That's why in treatment wise, in osteoporosis we need pharmacological therapy. In osteopenia we can go for dietary modifications and lifestyle changes. That is enough in osteopenia, because till osteopenia the bone will be somewhat will be good. The bone loss will be not much severe, but in osteoporosis what will happen? The bone loss will be more severe and the bone become more porous. Come to epidemiology. One in every 3 women over 50 years they will suffer from osteoporosis, and 1 in 5 men over 50 years they will suffer osteoporosis. In women are more prone for fractures. 15 to 30% of men and 30 to 50% of women are suffer from fractures. See this, men around 15 to 30%, but in a woman around 30 to 50% are more prone for fractures. If you come for incidence in Western countries, around 70 to 80 years they will for more prone for fractures. In India, 50 to 60 years only they will more prone for fractures. Why in women are more prone for fractures? There will be the 3 times are more common than men, because of in women what will happen? There will be the low peak bone mass. I will tell you what is peak bone mass. There in a woman there will be the low peak bone mass and hormonal changes at menopause, and after they attain menopause the estrogen levels will be too low, which is main responsible for bone formation. After menopause it will the estrogen secretion will be stoppage of estrogen, so there will be the high chance of osteoporosis. And women are live longer than men when compared to with men. They will be much more longer life. That's why in women the osteoporosis is more common. And coming to the most common sites, that is vertebra, whether compression fractures in vertebral and hip fractures, that is whether intracapsular, extracapsular, in hip and wrist also, that is Colles or Smith fracture or Barton's fractures, whatever the site will be more, these three sites are more common sites for more prone for fractures, that is vertebral, hip and wrist. Composition of bone, mainly by matrix and cells. Cells, that is those cells are osteoprogenitor cells, osteocytes, osteoblasts and osteoclasts. In matrix it will be in organic and inorganic. The calcium and phosphorus will come under inorganic, while organic are collagen, non-collagenous proteins and mucopolysaccharides. Just listen, the composition of bone mainly matrix and cells. In cells, that is those are osteoprogenitor cells, osteocytes, osteoblasts and osteoclasts. In matrix, that is organic and inorganic. In inorganic, calcium and phosphorus are inorganic, and organic are collagen, non-collagenous and mucopolysaccharides. Coming to the cells, that is osteocytes. Osteocytes are mononuclear cells. These cells are under the influence of parathormone, because if the parathormone is more, the osteocytes will be more secretion. So what will they do? What the osteocytes are do? They'll participate in the bone resorption, that is bone damage purpose, bone resorption purpose. The osteocytes will be, whenever needed, the osteocytes will be produced more. And calcium ion transport also, the osteocytes will be important. Osteoblast cells, these are mesenchymal cells which are responsible for bone matrix, and these osteoblast cells are type 1 collagen and non-collagenous bone proteins. Because osteoblasts, just remember, osteoblasts are bone forming cells. Okay, they are mainly secretion for type 1 collagen and non-collagenous bone proteins. Osteoclasts, these are the bone resorbing cells. Osteoblasts are bone forming cells and osteoclasts are bone resorbing cells. Coming to matrix, matrix in which collagen and non-collagen substance is there. In collagen, type 1 collagen is important, because in type 1 collagen is mainly produced by osteoblast cells, and 80% of unmineralized bone matrix in this type 1 collagen. And non-collagenous proteins, those are osteopontin, osteonectin and osteocalcin. These are the non-collagenous proteins. Okay, osteopontin, osteonectin and osteocalcin, these are the non-collagenous substances which are mainly regulation for bone cells and matrix mineralization. And bone morphogenic proteins, these are the growth factor proteins. What they will do in any fractures, if any non-unions, any delayed unions and bone defects, in those patients, if you inject the bone morphogenic proteins or growth factor proteins, there will be the revascularization and there will be the union will be more if you inject the growth factors. Delayed union means at least you will see up to 6 to 9 months. Still, if the bone is not united, that we will call as non-union. Delayed union means it will take more than 3 months to union. It is called delayed union. Non-union means it will take 6 to 9 months till the bone won't unite. Then it is called as non-union. Pathophysiology, it is mainly based on peak bone mass and bone remodeling. Peak bone mass means the bone mass is maximum mass of bone achieved by an individual. That is the age 25 to 35 years. This is the age the peak bone mass will be maximum. Higher level. Thank you. Peak bone mass, peak bone mass is maximum mass of bone achieved by an individual. That is the age between 25 and 35 years. Between the 25 and 35 years, this is the peak bone mass for everyone. After 35 years, in both women and men, the bone mass will be reduced. That what will happen? The bone mass will over the remaining lifetime, the bone mass, it won't go for peak bone mass. Once it is achieved the peak bone mass, after that slowly, it will gradually, the bone mass will be decreased. Because of subsequent bone loss, that's why the peak bone mass is an important factor for osteoporosis. In bone remodeling, it is mainly for if any damage in the bone or micro damage within the skeleton, to maintain the skeletal length, the bone remodeling is important. Mainly the calcium and phosphorus, and to supply the calcium, maintain the serum calcium levels. Whenever the calcium level is low in blood, from the bone, the calcium will release, and it will take up by the blood. That's why to supply the calcium, to maintain the serum calcium levels, bone remodeling is important. Coming to classifications, mainly two classifications, that is Norden and Ricks and Melton classification. Norden, he described osteoporosis into generalized and localized. And Ricks and Melton, they divided the osteoporosis into primary and secondary osteoporosis. This classification is important. That is, Ricks and Melton classification is important. Just remember primary osteoporosis and secondary osteoporosis. In primary osteoporosis, there will be the two types. Type 1 is postmenopausal. That means in women's postmenopausal, that means around 45 years or 40 to 45 years, that those people are prone for osteoporosis. Type 1, that is primary osteoporosis. The type 1, it is postmenopausal. Type 2, it is senile. That means age related. That is men more after 60 to 70 years, those will go for osteoporosis. Primary osteoporosis, type 1 postmenopausal, type 2 it is senile or age related, and secondary osteoporosis. Coming to postmenopausal osteoporosis, what will happen in this osteoporosis after they attain the menopause? Due to lack of estrogen, the estrogen level will be decreased, so that the bone resorption will be more. That is, the osteoclastic activity will be more in postmenopausal women. That due to lack of estrogen. If estrogen level will be there, then there will be no osteoclastic activity. Osteoblast activity will be there, but due to lack of estrogen, there will be the osteoclastic activity, and lack of estrogen increase the bone resorption. Age-related osteoporosis, that is around 70 years. That is age-related. It's not like some other diseases. Simply age-related. That is senile osteoporosis due to calcium deficiency or decreased bone formation, because over the period of long time, by the 6th and 7th decade in life, the bone formation will be reduced. After 40 years only, the bone formation will be reduced. That's why in these patients, the hip and vertebra and radius also most prone for fractures. Secondary osteoporosis, as I discussed, of postmenopausal and age-related, that is senile. And secondary osteoporosis, so many conditions other than the postmenopause and age-related, all other will undercome secondary osteoporosis. That is endocrine, metabolism, collagen deficiencies, any medications, any nutritional malignancy, and miscellaneous. Endocrine means acromegaly, amenorrhea, diabetes, hyperadrenocorticism, hyperparathyroidism, hyperprolactinemia, all these will come under endocrine. These patients also will go for osteoporosis. Even proton pump inhibitors, if you use long-term medication, proton pump inhibitors will go for osteoporosis. And calcium deficiencies and Heller-Danlos syndrome, collagen diseases, that is glycogen storage, homocystinuria, Marfan syndrome, osteogenesis imperfecta, and some of malignancies like lymphoma, leukemias, multiple myeloma, sickle cell disease, and any organic failure, that is liver failures or renal failure, and tobacco use. This is the most common also. Tobacco use high caffeine. If anyone takes regular coffees, it will take a lot of caffeine, means they are also more prone for osteoporosis. And multiple sclerosis, all these will come under secondary osteoporosis. Okay. Clinical features, the disease is also called osteoporosis, is also called as silent disease. The patients usually complaining of low backache, that is usually mild, and loss of height. Why loss of height means, if in osteoporosis, what will happen, the vertebral fractures will be more common. So if the vertebra will become fractured, the spine will become kyphotic, that is forward bending of the spine. That is the kyphotic deformity will be more in osteoporosis. That's why kyphosis. And the fractures most commonly vertebral and hip fractures. This is the vertebra showing the fracture. That's why their deformity will be that is the kyphotic deformity. Compressed vertebra leads to an kyphotic deformity, that is forward bending of the spine. And wrist also most common, that is distal radius. Whether it is if the fragment is dorsal, we can call it collis. It's in volar side, means we can call it as Smith fractures. And hip also, any intertrochanteric fractures, intracapsular neck of fractures, all these are common. These three uh, these three are the commonest sites which are more prone for fractures in osteoporosis. What will you examine in osteoporosis people? And see, this is the first test, that is wall occiput test. In this test, what will ask the patient to stand straight towards the wall, and heel touches the wall. Heel, calf muscles, buttocks, and scapular region and head should touch, normally should touches the wall. But in osteoporosis bone people, due to an vertebral body fracture, they have kyphotic deformity. So due to that kyphotic deformity, there will be the distance between the wall and occiput. Normally there will be the no space between the wall and occiput, but in uh, osteoporosis it will be the positive. That means there some distance will be there, at least 1 centimeter or 2 centimeter, whatever. That if the wall distance will be more than 0 centimeter, they are having it is an positive test results, that is wall occiput test. Another test is rib pelvis distance test, that is from the lower rib, ask the patient to stand straight from the lower rib to and iliac bone. We'll see the how much the space or how much the distance will be there. Normally it will be around 3 or 4 fingers will be space will be there between the lower ribs to iliac bone. But in osteoporosis patients, the distance will be decreased, because if any lumbar fracture, the distance will be narrowed. That is only two less than or equal to 2 finger breadths only will be there in osteoporotic bone. Diagnosis, we have to do routine physical and history and physical examination. We have to do for complete blood picture and biochemical tests, and we go for a blood urea nitrogen calcium levels. We have to see phosphate and alkaline phosphatase also, and vitamin D levels and parathormone, because parathormone mainly purposeful for osteocytes, that is bone resorb wherever the bone resorption cells, and thyroid stimulating hormones test, that is T3 and T4 and TSH also, and 24-hour urine test, that is calcium and creatinine levels we have to check out. And we have to see the testosterone for men and estrogen and progesterone levels for women also, that is follicle stimulating hormone, luteinizing hormone, and prolactin levels for in any young uh, amenorrheic women. Okay, these are the tests we have to do for osteoporosis patients. Imaging, come to imaging, that is the main that is x-rays. First is x-rays. X-rays, what you will see in osteoporosis bone, postmenopausal osteoporosis, that is after they attain the menopause, they're having trabecular resorption and cortical resorption. It is a more common in vertebra, that is trabecular resorption will be there and cortical resorption, both the inside the bone matrix and both will get affected. That is resorption means both will be affected in postmenopausal. When in senile osteoporosis, that is age related osteoporosis, endosteal resorption will be there. Cortex will be normally cortex will be there. Inside the cortex, the bone resorption will occur. That is due to age related. That's why it's called as senile osteoporosis, in which industrial resorption. Remember all this, because all these are for your NEET entrance exam questions. Postmenopausal osteoporosis, in which trabecular resorption and cortical resorption will be there, while in senile osteoporosis, that is endosteal resorption will be there. And hyperparathyroidism, that in hyperparathyroidism, it is mostly affect the phalanx, that is phalanx mostly proximal or middle or distal phalanx. in which there will be the subperiosteal resorption. That means subperiosteum means outer surface of the cortex will be resolved under the periosteum. Between the periosteum and cortex, the resorption will take place. That's why it's called a subperiosteal resorption in hyperparathyroidism. This is the score for vertebral fracture, that is a clear and copper score. In normally there will be no damage. The height will be well maintained. That is grade 0. In grade 1 mild deformity, that is 20 to 25% of the vertebral height will be decreased in grade 1. That this is normal. This is grade 1. This is the grade 2. Grade 2 means moderate deformity, that is around 25 to 40% of the vertebral height will be decreased in grade 2. And in grade 3 more than 40%, that is half of the vertebral body height will be decreased. This is the grade 3. That is a clear and copper score. In osteoporosis, we'll see the how much the vertebra will become damaged. We have to score according to this. And hip trabeculae, normally in hip the trabeculae will be present. That is trabeculae, these are the condensed part. That is see the principal trabeculae, that is at the head levels, and the secondary compressive is there, primary compressive, secondary compressive groups, primary tensile groups, and greater trochanteric. These are arc-like substances which are seen on X-rays, not in CT or MRI. Which plain X-ray we can see all these trabeculae. What will happen in osteoporosis? All that gradually if the osteoporosis increase, the trabecular pattern will be decreased. That's this is the scoring given by the osteoporosis. This is the called as Singh's index, SINGH, Singh index. Okay, grade 6 means that is normal. All trabeculae are well seen on X-ray. From grade 6 to grade 1, slowly the trabecular pattern will be decreased. In grade 1, there will be only the principal compressive trabeculae is we can only one trabecula, that is compression trabeculae will be seen. All other trabeculae will be gradually reduced. Just remember, for osteoporosis, what is the index we can see is, that is the Singh index, based on the trabecular pattern. Okay, trabecular pattern which is seen on plain X-ray, not on CT or MRI. Which is seen on plain X-ray, the trabecular pattern will be seen. Totally 6 grades will be there. Grade 6 is well visualized. All the trabeculae will be visualized. In grade 1, only the principal is compressive trabeculae will be there. What is BMD? That is bone mineral density test. How can we see? How can we do? I'll tell you. It is the amount of mineral matter per square unit area of bone. If they take any radius or lumbar spine or greater trochanteric, they will take the per units per square unit area, how much the mineral matter will be there in that. That is the bone mineral density, which is measured by DEXA scan. DEXA means dual, sorry, E is not there, dual energy X-ray absorptiometry. DEXA scan. BMD is calculated by DEXA scan, dual energy X-ray absorptiometry. At what parts they will see? That is the radius, lumbar spine, and greater trochanter. These 3 areas they can measure by DEXA scan to measure the bone mineral density. What are the indications for bone mineral density testing? In women more than 65 years and 70 years more than older in men, we can go for BMD testing. If they have symptoms or not, we can go for BMD testing. That is not a problem. And if postmenopausal women more than 50 years and if they have any fractures, how they will be in osteoporosis fractures? They don't have any high trauma injuries, even trivial trauma, that is slip and fall, that any minimal trauma, they have fractures, that is whether vertebral fractures or wrist fractures. In those patients also we can go for bone mineral density tests. That's why in postmenopausal who attain the menopause, even after 45 years also we can go for BMD testing. Okay, DEXA scan, the BMD testing mainly based on DEXA scan, that is dual energy X-ray absorptiometry. It is introduced in 1987. What they will do, it means there will be the two beams will be there. That's why it's a dual energy extra absorptiometry. That is two beams detectors will be there. In that is 70 kilowatts and 140 kilowatts will be measurements will be there. That's why it's called an DEXA scan. Sites most common central DEXA means they will go for lumbar spine or hip. Peripheral DEXA means they will go for radius, that is radius, forearm radius or calcaneum region. They will go for peripheral DEXA scan. Contraindications for DEXA scan: absolute contraindication in pregnancy. Normally we won't do any x-rays also, even normal x-rays also we can't do in pregnancy, because there will be the high chances of malformations. That DEXA scan, that is an absolute contraindicated in pregnancy. And any radio opaque implants in measurement area, because if you previously if you on any operations, any surgeries, orthopedic surgeries, any implant will be there, those patients also contraindicated for DEXA scan. And marked obesity, the body mass index, BMI, if a BMI is more than 35, that is overweight or obesity will be there, in those patients also the DEXA scan is contraindicated. And any patients who are allergic to contrast, these patients also are all contraindicated for DEXA scan. In BMD, that means bone mineral density, what they will see, that they will see the T score and Z score. What is T score and what is Z score? In T score, what they will take, the patient's measured BMD, they will get the bone mineral density from through DEXA scan minus mean bone mineral density of normal young population. Normal young population means around 30 years, 30 to 40 years of young population. They will take that mean BMD, bone mineral density. They will take, and they will take the standard deviation of bone mineral density of normal young population. That is the T score. Two score, that T score and Z score both are important, but mainly they will take only the T score will be consideration, because they will calculate along with the normal young population. In Z score, what they will take the patient measure BMD in with along with same age mean BMD will be take. If the patient is around 50 years, means they will take mean age of 50 years of BMD patients. They will take, they won't take normal population. If the patient is 60 years, means they will take that is calculated chart will be there. Before calculated chart, all the BMDs 60 years age group BMDs will be there. They will see that mean age group. Z score, they will compare with the same age only, but in T score they will compare with the normal young population. That is the T score. Normally the T score will be normal for everyone, that is will be more than -1. In osteoporosis, it is less than -2.5. If there is between the -1 to -2.5, means that is osteopenia. Okay. Coming to management initially, first we'll go for non-pharmacological, that is any nutrition, lifestyle modifications to prevent the prevention of fall, and hip protectors. These are will come under non-pharmacological prevention. And in any measures means after that, if not subject, then we'll go for a basic therapeutic measurements, that is are the vitamin D and calcium supplementations, any estrogen, that is the hormone replacement therapy. And if in severe patients, we'll go for anti-resorptive agents or drug stimulating bone formation. These are the calcitonin, bisphosphonates, and selective estrogen receptor modulators, denosumab. All these will come under anti-resorptive agents. Sodium fluoride and vitamin D analogs, all these are under come under drug stimulating bone formation. What is the best treatment means bisphosphonates are the best for the osteoporosis patients. But in these bisphosphonates also there will be the contraindications will be there, and in side effects will be there in bisphosphonate. So other than the bisphosphonates, what means calcitonin and this sodium fluoride, selective estrogen receptor modulators. In women, so we can go for hormone replacement therapy also. And dual action drugs with dual action, that means strontium ranelate. Remember this drug name, strontium ranelate. It have both resorptive agent action and a bone stimulative bone formation. It have both action, dual action. This drug has dual action. We'll see one by one. Non-pharmacological treatment, that is diet changes. Will advise the patients to well balance the diet with adequate calcium and vitamin D, which is mainly essential for bones. That is calcium and vitamin D. Calcium contributors, everyone know, dairy products like milk, yogurt, cheese, cottage cheese, and fortified orange juices and soya products. All these are rich in calcium contribution, rich in calcium. And vitamin D, we won't get vitamin D through food. It will get few. Vitamin D comes from sun induced only. That means sunlight only, because the vitamin D in skin, it will convert the vitamin D. So it in foods you won't get, simply you won't get vitamin D levels. Some foods are there, but low quantity of vitamin D levels only. High if anyone needs a high vitamin D levels, mean that is through sunlight only. Some vitamin D contributor, that is fatty fish and unfortified foods, because in this side effects will be there. That's why vitamin D mainly through sunlight, but these fatty fish and unfortified foods also better for vitamin D. And physical activity, uh, we have to say all these things to patients, because like that is nutrition and lifestyle modification. What lifestyle modification means? Physical activity, weight bearing and muscle strengthening exercise, because if you improve the bone strength, that will be through exercise only, not other than exercise. They can go for walking or any, not heavy exercise, not like a gym and all. It is simple normal exercise, normal walking, cycling, stretching exercises, swimming. All these are better, and they will improve the bone strength up to 30 to 50%. It will reduce osteoporosis. It will normally everyone, senile osteoporosis means age related. Everyone will get from 45 to 60 years, so they are more prone for fractures. If they do exercise, means the osteoporosis will come after 80 years only, not before that. Till what time they can do exercise? Exercise should be done there lifelong, at least for 45 minutes to 1.5 hours they have to do daily. And cessation of smoking, alcohol, and high caffeine intake, that is in caffeine intake also will more prone for osteoporosis. So we have to stoppage of smoking, alcohol, and high caffeine, and adequate sun exposure, which is mainly responsible for vitamin D. Okay, these are the hip protectors. There will be the soft cushion like products will be there. It will prevent, if any fall will be there, it will prevent, it will act like cushion like effect. So there will be the less chance of hip damage, that is a less chance of fractures. Okay, pharmacological prevention, that is calcium. Normally mean age population, that is 50 to 70 years of any age group, are men or women, they can consume up to 1000 milligram per day of calcium they can take. If the woman is age more than 51 and men more than 71, they can take up to 1200 milligram per day of calcium. They can take up to 1200. They can take up to 3 to 6 months also. That's not a problem. If it exceeds 1200 to 1500 milligrams per day, there will be the chances of kidney stones and cardiovascular disease and stroke. That's why in mean age population, better we can advise calcium products, which are from dietary. If they are really prone for osteoporosis, then we can advise up to 1000 milligram or 1200 milligrams of calcium, but not more than 1500 milligram per day. If they take any 1500 milligrams, so means there will be the chance of kidney stones and cardiovascular diseases, that is sure. Vitamin D, how much they can take? Vitamin D, they can take up to 800 to 1000 international units per day. They can take. If those patients are more than 50 years, they can take up to 800 to 1000. This is the for prevention sake, that is 800 to 1000. If for any deficiency patients, we can give 60,000 or 50,000 international units once a week. Vitamin D are available in capsules, it will be there, liquid form is will be there, and the sachets packets also will be there. These are the they have to take along with milk or some water also, that's not a problem. They will take weekly once only. If they take on Monday and next Monday only they can take. Up to how many weeks? That is up to 8 to 12 weeks. 8 to 12 weeks they have to take weekly once. That is the vitamin D for that in deficiency patients. Okay, till how much normal vitamin D normal levels is 30 nanogram per milliliters. Till we reaches, we can give up to 8 to 12 weeks. If they achieved 30 nanomilligrams per milliliter in 8 weeks, we can stop it. That's not a problem. That's why there will be the range. Minimum they can use up to 8 weeks. They can use up to 8 weeks. Still if it is low level, then they can use up to another 4 weeks. That is the vitamin D. And after that, if after 8 weeks or after 12 weeks, if they attain 30 nanogram per ml, don't stop the treatment. They are then shifted to normal maintenance therapy, that is 1500 to 2000 international units per day. They can take tablets. And come to bisphosphonates, these are all the pyrophosphates. Main mechanism of action is to attach the bone remodeling sites. Wherever needed, it attaches the bone remodeling sites, and it promotes the osteoclast apoptosis. So there will the bone growth will be there in those patients. That's in bisphosphonates. So many drugs are there in bisphosphonates that we'll discuss. Alendronate and pamidronate, zoledronic acid, all these are bisphosphonate. In that alendronate, for prevention sake, that prevention sake means before fractures, or if around in 35 to 45 years they can use. That is the prevention period. Prevention means how much they take, that is 5 milligram per daily, or 35 milligram weekly tablets also available. If any osteoporosis means how much the treatment wise means, we can use that 10 milligram daily tablet or 70 milligram daily tablet. For prevention, we can use half dose only, not complete full dose. In treatment, we can use 10 milligram of our weekly tablet, that is 70 milligram. Is used in treatment of osteoporosis in both men and women. We can taking glucocorticoids. Okay. Ibandronate, the treatment is 150 milligram per monthly tablet, and 3 milligram every 3 months by intravenous injection also available. That is ibandronate. And risendronate, that is both for prevention and treatment. The dosage is same only. That is 5 milligram tablet daily tablet, or 35 milligram weekly tablet is available. Zoledronic acid, this is the most important drug in bisphosphonates. Can treat osteoporosis immediately, but the side effects also more in zoledronic acid. How they will give? It is given by intravenous injection. That is how much for both prevention and treatment. They will give 5 milligram by intravenous infusion. How much time it will be given? Around 15 minutes we have to give. Don't rush within 1 or 2 minutes. And how many times we can give? 5 milligrams intravenous, around 15 minutes duration, once a year. Once a year only we can give, not twice or thrice. Only once a year we can give zoledronic acid. If the patient has severe osteoporosis, then we can give if we can give once a time. If the patient needs for prevention and all, they can give, and once every 2 years for prevention. Every 2 years for prevention sake we can give. Drug administration, all these bisphosphonates we can give, oral tablets they can take early morning only. All bisphosphonates, whether zoledronic, risendronate, or pamidronate, whatever the tablets, they should be taken early morning on empty stomach, at least 60 minutes, that is 1 hour before the breakfast only they have to take. And after that they won't get sleep. The patient should sit up straight for 1 hour, at least 1 hour they have to wait. Okay, no need of walking, no need of exercise, nothing. Just they have to take the tablet and they have to sit up straight for 1 hour. That too empty stomach only. They should not take any other medication also. Okay, empty stomach they have to take. What is the side effects for bisphosphonates? That is gastrointestinal problems and esophagitis and gastritis. To reduce those that for the drug safety, we have advised early morning tablet and ask the patient to sit up straight for at least 1 hour. Don't forget tell these things to patients who are using oral bisphosphonates. Okay, and these bisphosphonates are contraindicated in patients who are glomerular filtration rate less than 30 to 35 ml per minute. The patient having less than 30 to 35 ml per minute, these bisphosphonates are contraindicated. In those patients only we can go for other medication, that is calcitonin, vitamin D analogs. Otherwise other strontium tablets will be there. All those medications are will come up. First we'll advise bisphosphonates only. If the patients have any contraindicated, then we can go for other medications. And if the patients have long-term usage of bisphosphonates, they can go for osteonecrosis of jaw. ONJ. This is one of the MCQ for interest. Osteonecrosis of jaw, which is can occur in long-term use of bisphosphonates, and atypical femoral fractures also more prone for in long-term bisphosphonates. What is the atypical femoral fractures means? That is other than the usual size. Normally in osteoporosis, ICNF or IT fractures will be the more, but in atypical fractures like in more prolonged use of bisphosphonate, there will be the chances of subtrochanteric as shaft femur fractures. Those are all the atypical femur fractures. Other than the usual size are called as atypical femur fractures. Calcitonin, how much they will give? They will give 200 international units. That is nasal spray will be available. They will take just nasal spray, that is like in asthmatic patient they will take puffs, no, in same like that calcitonin sprays will be there. They will take 200 international units delivery. They will take just only 1 or 2 puffs, that's it. Okay, in which patients, that is osteoporosis with postmenopausal patient, that is after 5 years, after 5 years of postmenopausal only they can take calcitonin. They can't take calcitonin immediately after that means immediately after menopause they can't take. At least after 5 years only they can take. That is intranasal calcitonin. International calcium, they will take that. The but side effects will be there, that is rhinitis, any allergic reactions, any epistaxis, any bleeding from the nose also. There will be the chances will be there with this calcitonin. And some cases are reported in calcitonin. There will be the high risk, that not high risk, that is a very small increase of risk of certain cancers also by using calcitonin. Hormonal replacement therapy in females, we can give for give estrogen, that is a hormone that is the main hormone which will be reduced in osteoporosis, that is the estrogen. We can give estrogen with or without progesterone. We can use, we can give estrogen directly. We can give estrogen along with progesterone also, that is there is no problem. But mainly in hormonal replacement therapy, estrogen is the one of the best drug. That is the only drug. Okay, how much dosage means 0.625 milligram per daily, that is the estrogen levels. Okay, and routes, the through oral route, that is tablets are there, and transdermal injections also available. And in hormone replacement therapy, what are the side effects? Coronary artery disease, stroke, pulmonary embolism, and invasive breast cancers are, these are all the side effects. Why these side effects? In some patients, out of 100 patients, there are some patients, 2 or 3 patients will have coronary heart disease. That's why if patients have any patients of coronary heart disease means we can't give hormonal replacement therapy. That's why the bisphosphonates and other drugs will be available. We had to take thorough history, take everything. After that only we can go for treatment. And paratha hormone, that is teriparatide, we can use in postmenopausal women who have more prone for fractures. We can give paratha hormone, that is teriparatide injection will be there. uh, the doses will be the 20 nanogram will be there. That is a subcutaneous injection. This is injection form only. There is no tablet form for paratha hormone, that is teriparatide. They will take subcutaneous injection daily. What are the side effects? Leg cramps will be there, nausea and dizziness for teriparatide injection. Contraindications in which patients increase risk of osteosarcoma, bone metastasis, hypercalcemia, and any skeletal malignancy also will be the contraindications of teriparatide injections. Only injection form is available, that is parathermal teriparatide injection. There will be the no tablet form for parathermal. Okay. Next, come to selective estrogen receptor modulators, that is relaxifene. Relaxifene. If any patients who are all contraindicated for bisphosphonates, who are all contraindicated for hormone replacement therapy, all these patients we can go for this selective estrogen receptor modulator, that is relaxifene. How much? How much? 60 milligram per day we can use. With these side effects, there will be increased risk of deep vein thrombosis, heart flushes, and leg cramps. All these in osteoporosis, the leg cramps is the most common. Also, if you use, if you whatever the drug, whether bisphosphonates, whether hormonal replacement therapy, all these patients may complaining of leg cramps. Okay, that is up to that. That is nutritional and medical. Now, what are the role of orthopedics and surgical management? Why we are going for surgeries? If any fracture will be there, we have to go for surgery, because rapid mobilization and return to normal function, they have to go for normal routine work. For that, we have to operate and avoid too much manipulations and progressive physiotherapy. If the patient have any vertebral fractures, we can normally, if the patient have any vertebral fractures without any neurological deficit, the patient don't have any neurological deficit, means we can go for conservative management. That is like this belt, the thoracolumbar brace. Thoracolumbar brace, that is DL belt or Tyner brace, we can call it as Tyner brace. Thoracolumbar brace, we can make the patient to sit straight or stand straight. Okay, if the patient don't have any neurological symptoms only, then only can go for conservative. If the patient have any neurological complaint, then we can go for surgical management. What are the surgical managements? See, one is pedicle screw fixation. That means, see this in middle one vertebra is damaged. What they will do, they will put screws in the upper and lower vertebra through pedicles. Into the vertebra through pedicles, they will put the screws, and those screws they will connect it to the rod, and they will distract that between the screws. So what happened, the space between this damaged vertebra will be increased, and there will be the relief of symptoms will be there. That is called as pedicle screw fixation. And vertebroplasty, what they will do in vertebroplasty, if the damage in the damaged vertebra, they will inject the bone cement through pedicles. In vertebral fractures, everything they will done through the pedicles only. Okay, in vertebroplasty, what they will do means, they will inject the bone cement into the vertebra. In damaged vertebra, why they will inject in cement? To prevent the further damage of the vertebra. If the vertebra damage occur up to 40%, if you inject the cement, so it prevent the further damage of the vertebra. Okay, that is called as vertebroplasty. In kyphoplasty, what will happen? They will inject the bone cement till the bone regain its original position. If the bone percentage will be decreased 40%, if you inject the bone cement, and to restore the vertebral height till 100% it achieves, that is kyphoplasty. Kyphoplasty means to restore the height of the vertebra, and vertebroplasty means to prevent further damage of the vertebra. Okay, that is in vertebral fracture we have to, will do these things: vertebroplasty, kyphoplasty, or pedicle screw fixation. In wrist fractures, that is any Colles or Smith fracture, any intra-articular fracture, if the fracture is undisplaced, that is Colles or Smith fracture, if the fracture is undisplaced, then we can go for cast, that is Colles cast. How they will apply Colles cast? In handshake position, that is 15 degrees of palmar flexion and 20 degrees of ulnar deviation. In that position they will go for, that is the position of handshaking, that is the where we'll apply for Colles cast. Okay, in undisplaced fractures only we can go for casting. If you go for operative management, that is the operation, two types of is there. One is open reduction and otherwise closed reduction with K-wire spinning. Just they will reduce the fracture site and they will fix with K-wires. Otherwise they can, if any intra-articular fracture, that is Barton's fracture, that is volar Barton's or dorsal Barton's, in any intra-articular fractures are displaced Colles or displaced Smith fracture, we can go for open reduction and internal fixation by with the plates and screws. Okay, in wrist fractures. In hip fractures, there will be several options will be there. Any intertrochanteric fractures, we can go for DHS, that is dynamic hip screw. This is the DHS, dynamic hip screw. Okay, otherwise can go for DCS, that is dynamic condylar screw, and PFN, that is proximal femoral nailing. Plasma femoral nailing, all these can go for intertrochanteric or intracapsular neck of femur fractures also we can go for intracapsular neck of femur fractures. Other than DHS and PFN, the prosthetic replacement, what means prosthetic replacement, they will remove the head and neck and they will replace with prosthesis. They will remove the femur head and neck and they will replace with processes, that is the bipolar or unipolar. That means the head will be movement will be there in bipolar, while in unipolar there will be the no movement between the stem and the head. Okay, that is unipolar or bipolar hemiprosthesis. In hip fractures we can go for what are the latest treatment in osteoporosis. Latest treatment, those are all the carotenoids and lycopene reduce fracture is whatever antioxidant that is now in market. So many things are available, antioxidants available, that is green lemon teas or green tea. All these antioxidants are decrease the osteoporosis. And omega-3 fatty acids, the foods which contains omega-3 fatty acids and reduce, what they will do means they will reduce high sensitivity C-reactive protein. They will reduce that C-reactive protein, so it leads to an to prevent the osteoporosis. And vitamin K, it is also important for bone strength and reduce fractures. Now they are using antioxidants, vitamin K and omega-3 fatty acids. Still the research is going on to prevent that osteoporosis. They are researching. These are the latest treatment. Other than the bisphosphonates and other drugs, they're using those drugs, and they're now they are adding their supplementation along with the antioxidants and this vitamin K. Thank you guys. Any doubts? Shall I close it, or any doubts is there? Any doubts, guys? Okay, thank you so much.